How many of them are ventilatory support, like, sir?
Ventilatory support, I think probably at this time there are 4 probably on the ventilatory support.
Okay. In Chennai, in our medical college, we have 276 patients, sir.
Okay.
It has been said that it's going to be worse than the first phase.
Madam, the incidence looks worse, madam, but the morbidity seems to be much lesser. That's what our physicians are telling, madam.
Morbidity, I think what you are talking is maybe because of vaccines already. Healthcare.
Possible, sir. Many factors are being told. Now, actually, Tamil Nadu government has given permission for the professors to use remdesivir as much as they want. Tocilizumab also is now available if a chief signs the drug. So it is so well they are organized now. So drugs are started much earlier, sir. So I think we can go on here. We had 8 o'clock. Good evening, friends. The faculty here, I once again wish a very good evening to all the residents and faculty, for all of them who have joined in the Zoom as well as the YouTube channel. Today we have 2 important exam cases. One is right mass and the other one is the renal mass. The candidates are Dr. Pujita from KMC Manipal. In fact, I should thank Shanai sir, because yesterday evening only I requested him and he was kind enough to get a PG for us. And I should thank Professor Ganguly sir from Jorat Medical College for giving the PG, Vimal Mazumdar with the right leg fossa mass. And we have our senior faculty, Khanna sir, Shanai sir, Karnakaran sir, Rajiv Sahai sir, always staying with us. We have a special guest, Ganguly sir, joining us. She's been with us for so many times. And today we have a very eminent faculty who have been invited to moderate the sessions. We have Professor Sujata Padwadan ma'am. She is the head of the urology at KM Hospital, Seth Medical College at Mumbai. Thank you, madam, for joining us this evening.
Sure.
And we have Professor Atiya Zakarab. She is from JNMC, Aligarh Muslim University, Aligarh, Uttar Pradesh. Thank you, madam, for joining us this evening. And we have Professor
mine, sir.
Thank you. Professor Manav Jyoti sir is kindly introduced by Professor N. Ganguly sir. Thank you, Professor Manav sir, for joining us this evening. And we also have Professor Srinivasan coming in. So, like, we will have the renal case first. I would now request Pujita to introduce herself, her unit chief, and start the presentation.
Yes.
To remind the invited faculty, take the precedence for the questions. Of course, others also will be chipping in for their comments. The candidate is allowed to present through the history part of it. Then questions are directed for the history segment alone. Then she is allowed to run through the clinical part of it. And the questions are initially directed to the clinical part and the diagnosis. And later, investigations and management. I would request all the faculty to kindly give the answers if the candidate is unable to answer the question. As an examiner, what is the right answer you expect? So this is how we plan. And the time given is 1 hour per case. So we will be roughly taking about 1 hour for the first case and 1 hour for the second case. If it is something very important, maybe 5-10 minutes extension can be considered. With that in mind, I invite and wish good luck to Dr. Pujita for her presentation. Over to you, Dr. Pujita.
Good evening, everyone. My name is Dr. Pujita. I'm a final year postgraduate from Kasturba Medical College, Manipal, and my guide is Dr. Rajgopal sir. Today, I shall be presenting the case of Mr. X, a 54-year-old gentleman, a farmer by occupation, hailing from Davangere, Karnataka. He came with the chief complaint of hematuria since 2 months. The patient was apparently asymptomatic till 2 months ago when he noticed he had one episode of hematuria. That is, he said there was reddish discoloration of his urine throughout the stream. It was not associated with any passage of clots. He had intermittent hematuria over the past 2 months with 4 episodes in total, and there was a period of around 10 to 15 days between each episode. There's no Mr. X, a 54-year-old gentleman. There's no history of any drug intake prior to the onset of hematuria. It was not, these episodes of hematuria were not associated with any pain initially. There was no history of any increased frequency of micturition or burning micturition during these episodes. However, 3 days ago, the patient had one episode of acute retention of urine. He did not pass urine for about 12 hours. And at that point, he had a sudden onset severe lower abdominal pain, for which he visited a local hospital. However, on arrival at the hospital, he passed urine spontaneously without the need of catheterization. And at that point, the passage of urine was associated with passage of thick clots. And the lower abdominal pain subsided after he had passed urine. He was evaluated with an ultrasound scan and referred here for further management. There's no history of any abdominal pain or loin pain. There's no history of any abdominal mass. The patient also complains of headache since the past 2 months. 1 month ago, he had one episode of severe headache and blurring of vision, which led to a fall from the bike. He did not have any loss of consciousness, vomiting, or seizures, and no other injuries. For this severe headache and blurring of vision, he had gone to a local hospital and he was told to have high blood pressure readings. However, he was not started on any medications. There was no history of any palpitations or sweatings associated with these episodes of headache. He also complains of a left-sided scrotal swelling, which he had noticed since 1 month, which was insidious in onset and non-progressive. And he noticed that the swelling was more predominant towards the end of the day and disappeared towards the morning. And this swelling was not associated with any pain. He also complains of weight loss of 3 kgs over the past 2 months with no decrease in appetite. However, there is no decrease in appetite. There's no any easy fatigability. There's no history of jaundice. There's no history of lower limb swelling. There's no history of any swelling anywhere else in the body. There's no history of low back pain. And there's no history of a cough with hemoptysis or breathlessness. The patient is a known diabetic since 10 years on oral hypoglycemic agents. He is compliant to the treatment and a regular follow-up with his physician. There's no previous history of hypertension. There's no history of chronic kidney disease and he's not undergone any dialysis. There's no history of ischemic heart disease, bronchial asthma, or tuberculosis. And there's no history of any previous surgeries. Personal history, his sleep and appetite was normal. His bowel habits were regular. And there's no history of any intake of alcohol or consumption of tobacco products. There's no significant family history. In summary, a 54-year-old gentleman, a known diabetic, presented with 4 episodes of painless hematuria over the past 2 months, with 1 episode of acute urinary retention due to blood clots, and recent onset left-sided scrotal swelling with newly diagnosed hypertension.
So, Pujita, actually,
Yes,
when we ask our MCA students to present the history of hematuria, okay, so the first most important thing which we consider is what was the hematuria like? Was it total, whether it was intermittent, whether it was gross, and whether it was painless and painful? You definitely mentioned that it was painless initially.
yes,
But whether it was gross and staining the entire stream is an important point. Then whether there were any clots associated with the hematuria, and if at all there were clots, whether they were amorphous and roundish in shape or whether they're serpentine in shape. This is the second point which we asked, suggesting that if they are serpentine, they are probably related to the upper tract. Okay, so apart from this, then we immediately go as to the severity of the hematuria. Was it self-limiting? Did the patient take any medications? Was he admitted for it? Did he receive any blood transfusions for it? Was he on any blood thinners at it? So all these things related to the hematuria go on simultaneously. Secondly, you mentioned that the patient was diabetic. So it could be also papillary necrosis. So were there any tissue bits with the hematuria, like whether any tissue bits were passed by the patient? This is an important history. So tissue bits, serpentinous clots or amorphous clots, gross, self-limiting or requiring treatment. I think these were the points you missed regarding the hematuria. So once hematuria is done, immediately we cover the symptoms related to the upper tract directly. So that would mean whether that the patient has presented with a lump in abdomen, whether he has noticed any fullness in the abdomen. So that would be covered second. And then we would go to whether he has history of any trauma also, because and history of stone disease, because in our country the most common cause for hematuria is not a malignancy. It is commonly related to stone diseases. So past history of stone disorders is what one point you missed. Then coming to the lower tract, see, the hematuria can be from the bladder. So if at all it is from the bladder, again, it would be associated with tissue bits, it would be associated with dysuria, it should be associated with storage symptoms like frequency, urgency, or nocturia. So this is the sequence in which we would go for the examination. Otherwise, I think you did a fantastic job at the history. I have nothing much to add to it. Lower urinary tract symptoms is a very important thing, because dysuria is a very important symptom for the bladder tumors, if at all they are. Okay. Then even a differential diagnosis would be a stone, like a bladder stone. It could be a urinary tract infection. So when a patient presents only with hematuria, with nothing else to it, I think the things which come to your mind should be stone, tumor, and infections. And of course, there are many more points. So I don't know what is your sequence of conducting. So I think maybe I would be a little
I
lost
think
in this presentation.
My connection got my net. I just logged in again.
no,
Sorry.
you're back with us. Madam was suggesting all the important points what were not added. Now,
Yes.
I think Madam can ask more questions, or I will request the other
Yeah,
faculty to ask
on,
questions.
yeah, on history, I think definitely we would ask a history of stone disease as a very important thing, because that's the most common thing in our country. Apart from renal lumps are not all that common. So hematuria would be, so history of fever with chills, history of pyurias, history of stone disease, or history of lithuria would play a prominent part in it. And history of any ongoing fever, history of tuberculosis also would play an important part in the history. I think these were the only things she missed. I think I should allow the other panelists to talk. I can take a break.
Yes, ma'am. Madam, other faculty and sirs can take over.
Vanita, you've taken history of recent high onset of hypertension.
Sir.
So what could be the causes of recent onset of hypertension? What's the importance of this recent onset
So
hypertension?
if a 50-year-old gentleman with hematuria and recent onset of hypertension, it could indicate carcinoma, because that is known to cause hypertension and hematuria.
No. What is the importance of hypertension associated? How is hypertension associated with renal cell carcinoma?
Sir, hypertension can be because of increased production of renin because of the tumor itself. And
Is it? Could we know? Is it?
Because so there are many because of increased renin production by the tumor, or it can also be because of the renal artery, which can cause renal artery stenosis and cause hypertension.
Okay, what are the risk factors? Sorry, what are the risk factors for RCC then?
Age, the male gender, or smoking, and even hypertension also is a risk factor
permission.
Right. So hypertension is one of the risk factors for RCC.
For RCC.
So what is, have you heard of what a gallbladder kidney? What's a gallbladder kidney? Have you heard of it?
No, sir.
Gallbladder.
Gallbladder.
क्या होता है? गोल्ड मतलब बीटन गोल्ड जैसे दिखती है.
Hello. Yeah, it's hypertension due to stenosis of the renal artery. In fact, Goldblatt was the one who discovered renin angiotensin. That's why it's named after him.
Yes, sir.
Right. So, like ma'am said, there are various histories for hematuria. What is initial hematuria? What is total hematuria? What is terminal hematuria? And what did they tell you?
So initial hematuria is when there is either reddish discoloration of urine or passage of blood in the beginning of the urinary stream. It's most probably because of a urethral pathology. Discoloration of urine or blood or passage of blood throughout the stream of urine, it's most probably an upper tract pathology, or it can be a bladder pathology also. And if it's only in the terminal part of the stream, it's most probably a bladder calculi or a bladder pathology.
So how will you distinguish this hematuria from bladder and from upper tract?
So if it's upper tract, it will be throughout. If they're passing clots, they can pass thin, long clots. The bladder, if it's bleeding from the bladder, the clots will be more amorphous and round. And also they might have some associated pain. If any loin pain or loin to groin pain can be from the upper.
Most important is dysuria. Pujita,
Yes.
most important is dysuria. Dysuria is always associated with the bladder.
And bladder pathology.
Right.
Yes.
You said the patient has a left-sided varicocele.
Left-sided total swelling was noticed. Yes,
which disappears. So probably a varicocele. So what is the cause of this varicocele?
Usually left-sided varicoceles are more common than right, and if it's a recent onset renal cell carcinoma on the left side, because the left renal vein directly drains. There's a more possibility of reflux and varicocele on that side. On the right side, it drains into the IVC.
Any other reason?
For the left-sided, and if there's tumor thrombus in left renal vein, it can cause left side renal left varicocele because of the obstruction of testicular vein.
Right. Okay, we'll talk about it later.
बच्चे का ऑपरेशन करें.
Based on these three very important symptoms you are given, the hematuria, the left-sided scrotal swelling, and a newly diagnosed.
Yes, sir.
Can you reach to a concrete diagnosis only by the history?
Yes, sir. Because I think it's most probably a left-sided renal tumor, renal cell carcinoma.
So how do you explain all those things?
So one, the painless hematuria is probably because of the renal tumor that is bleeding into the calyceal system, and it comes into the urine. And the recent onset left-sided if a left-sided scrotal swelling could be a varicocele, and that could be, like I said, because of the obstruction, a tumor thrombus in the left renal vein, which is causing obstruction of the left testicular vein. And newly diagnosed hypertension can be because of either renin production by the tumor or any renal compression of the renal artery by a renal tumor, or also hypertension can also be because of any AV malformations formed within the tumor in the left kidney.
So can you explain to me why your diagnosis is a renal tumor, and that too you are going ahead and giving a differential pathological diagnosis of an RCC,
right.
And why is it painless then?
You cannot do that.
Because the renal tumor starts in the substance of the kidney, right?
Yes,
so it will produce a space occupying effect in the kidney. So when it is stretching the capsule, why is it painless?
Sir, ma'am, not all renal tumors are painful. Few of them might be painless.
No, Pujita, sorry.
So if it is painless, then you would suspect that it is very small in size.
Okay.
A small renal mass is
But
what
slowly,
you think.
probably slowly growing, ma'am, and it's not.
If it's slowly growing and it is a big mass, it will stretch the capsule and cause dull aching pain. But if you are categorically saying it is painless, then either it is arising from the renal pelvis or it is small in size, right?
Yes,
that's common sense, right?
Yes, ma'am.
Do you have a differential diagnosis?
Other thing maybe can also be a bladder tumor.
With no bladder symptoms.
Only hematuria, nothing else.
Why is it not papillary necrosis? Patient is diabetic.
Then, ma'am, is it? I'm not sure if it's possible to have a left-sided varicocele. Then it can be. I'm not sure.
But we have not reached the clinical diagnosis of varicocele.
Yes,
We are
yes, ma'am.
saying it's a scrotal mass. It could
Yes,
be a
ma'am.
hydrocele. It could be he's got hurt. Maybe he's got. We can't label it on history as a varicocele. Unless you give us very pointing things to label it as a varicocele. Like the patient says on Valsalva manure, it increases in size. When it lies down, it decreases in size. Something very specific. So
I think she said so.
it could be still possible. So what would be your differential diagnosis?
And may I interject a little? I think the child said very much clearly in the beginning that the swelling reduces when the person lies down. That is what you said, no?
Yes, ma'am.
So
Yes, I noticed.
he said that very categorically.
But
So,
it could be a hernia, which reduces when the patient lies down.
what was the nature of swelling? Where was it actually feeling? Was it feeling from the top or was it feeling from the bottom of the
The patients, I noticed only a scrotal swelling. He did not notice from where, and he also did not say there's no associated dull aching pain with it. He just said it. He notices predominantly towards the end of the day, and it disappears on lying down. And it's not much in the morning when he wakes up.
Did you sorry.
Yes, sir.
You should not come to a pathological diagnosis at present, right? You should refrain from that. Yes. Otherwise,
it could be a tumor arising from the ureter also. Upper part of ureter, transitional cell carcinoma in upper part of ureter could also lead to this kind of symptom. But then, of course,
they'll have pain. Right?
Pain is likely to be there.
Yes.
Classical triad for the renal tumor.
It's hematuria, loin pain, and loin mass.
So what is absent in your triad?
What is?
What
pain
is
not there. Pain is in there, sir.
Pain is not there, and also lump is not there.
Noticed.
So pain and lumps are missing. In
Yes.
how many % of cases this triad is positive? That you get all the three things? Majority of the time it is absent.
Yes, sir. Only in less than, yes.
In about 20% cases, this triad will be positive. But the way you have described, in this age group, a patient having a painless hematuria, which is there, with probably the patient has got the varicocele. You cannot think about that there will be in the short period, there will be hernia will be there. And the patient is having a recently diagnosed hypertension. I think you are very right to say that you can pinpoint your diagnosis that probably you are dealing with a case of renal cell carcinoma only based on the history. There may be differential diagnosis may be there. I do not say that it's not there. But your first diagnosis can come. Many times we give the pathological diagnosis, like is a parotid tumor, we say it's a pleomorphic adenoma. That's a pathological diagnosis. Okay. So similarly here also you can say that it's in this age group, what other tumor will be there? You're not thinking in terms of Wilms tumor here. Okay,
No,
you are
sir.
only thinking of the cancer which is a renal cell carcinoma. So you are very right to say that probably you are thinking in terms of the renal cell carcinoma in this patient.
I have one or two questions. I'm internal for her. What is the other renal mass associated with the hematuria other than RCC or transitional cell carcinoma? Can you name any other mass associated with the hematuria, renal mass? Forget about this patient for the time being. I think she's frozen.
Sir, can you hear me?
Yes, yes. You can switch off your video. Probably it's a little
Okay.
bandwidth. Yes. Yeah.
I said angiomyolipoma.
No. More angiomyolipoma causing hematuria. Oh God. No. Anything else? I said forget about the age for the or whatever it is.
Wilms tumor.
Child. Oh, okay, I'll put it like 45-year-old lady, hypertension and hematuria, kidney mass. Bilateral. Come on. Bilateral. Hematuria.
Polycystic kidney disease.
Don't forget, no? So it's not that some of the polycystic, they do, not that everyone goes for a renal failure soon. Okay. So hypertension, hematuria, always consider renal cell carcinoma and
Mucus ले लीजिए.
also.
Mucus.
Did you ask history of fever? Fever?
Yes, so he does not have history of fever.
So why it's important?
If
I think.
neoplastic syndrome, they might have fever.
Can you tell me any other mass in the abdomen which can present as fever? Not kidney, something else. RCC is one.
Hepatocellular carcinoma can also present as pyrexia of unknown origin.
So before the days of ultrasound, people have put a needle into liver cell, the renal, hepatoma, thinking that it's amoebic liver abscess. In India, liver abscess used to be quite common. That's all from my side, sir. Please.
Go on the examination now.
Okay, sir. On general examination, the patient was examined after taking consent in the privacy of a well-lit room. He was conscious, cooperative, and oriented to time, place, and person. He was moderately built and nourished with a BM. His ECOG performance status was 0. Pallor was present. There was no icterus, cyanosis, clubbing, generalized lymphadenopathy, regular rhythm, and normal volume. His blood pressure was 180 sitting position. His respiratory rate was 14 breaths per minute, and he was AFib. On the abdominal examination, on inspection, the shape of the abdomen is normal. All the corresponding regions move well with respiration. The umbilicus is central and inverted. Left renal angle fullness is present. There is no the right renal angle fullness. Right renal angle is present, which is more prominent when the patient was standing. On palpation, a vague mass was palpable in the left hypochondrium and lumbar region on deep in size, extending 8 centimeters below the left costal margin and 8 centimeters away from. Borders are not very well defined. The upper border was not palpable, and the fingers could be insinuated below the left costal margin. The lower border was vaguely felt 8 centimeters below the costal margin, and it moves with respiration. The medial and lateral borders are not very well defined. The mass was firm in consistency with a smooth surface, and it was non-tender. It was bimanually palpable and ballotable. There were no pulsations over the mass. Left renal angle fullness was present, and there was no fullness and no mass noted. Both the hernial orifices were normal. Left scrotal swelling was present, which was soft and compressible. It was non-tender. It was present, palpable above the testis. The testis were palpable separately and were normal. It was a grade 3 varicocele. And on percussion, a left renal angle dullness is present. A resonant note was present over the mass and the rest of the abdomen. There's no free fluid present, and the liver span was around 12 centimeters. On auscultation, there was no bruit heard, and normal bowel sounds were present. And per rectal examination, there was no prostatomegaly, and there were no palpable deposits. And left supraclavicular node was not palpable. On systemic examination, cardiovascular system was normal with S1 and S2 was heard, and there were no murmurs. Respiratory system, bilateral normal vesicular breath sounds were heard. Skeletal system, there were no palpable swellings, and there was no bony tenderness. And CNS examination, there were no focal neurological deficits. In summary, a 55-year-old gentleman, known diabetic, presented with 4 episodes of painless hematuria over the past 2 months, with 1 episode of acute urinary retention due to blood clots, and a recent onset left-sided scrotal swelling, and newly diagnosed hypertension. On examination, BP readings were recorded with a vaguely palpable mass of approximately 8 into 4 centimeters, occupying the left hypochondrial angle fullness, probably a left renal mass with left grade 3 varicocele present. So my diagnosis was probably a left-sided renal cell varicocele.
Can you go to the general examination slide just to start discussion? Others can take over. Go to the general examination slide quickly,
Yes.
because in between I think your bandwidth was poor, so I think it was. So anything very specific thing you have mentioned here is the pallor.
Pallor was present, sir, and blood pressure was high.
Just hold on. One of the questions which is asked is how do you explain the pallor in RCC without hematuria? Without hematuria, yes.
So in patients with RCC, at times there might be a reduction because of the tumor occupying the renal parenchyma. There might be reduction in the production of erythropoietin, and they might have anemia because of that.
So these are postgraduate few questions. Like one other question is why anemia in carcinoma of the stomach even without bleeding or nutritional? For that, his answer is hypochlorite.
Iron deficiency and
Iron deficiency, severe achlorhydria. So these are few standard questions. Anemia in the absence of hematuria. That is the reason I asked you this. So you have written that icterus, cyanosis, clubbing, edema. Out of which, what is important? Out of those 4, 5.
any pedal edema, sir, if it is present.
So which side? Both side or unilateral?
It's bilateral because of
Bilateral? Not that you can't get bilateral. Hello? Yeah,
hello. Yes.
What is important is bilateral pedal edema is usually physician's work, but
yes.
Expect something, unilateral lymphedema, whether it's a DVT, whether it's a local issue,
Yes.
or whether it's a IVC, common iliac, all that. Okay.
Yeah.
Sir, please take over.
Are there any specific cutaneous manifestations for renal tumors?
I'm not sure, ma'am. I think I can.
Which is the familial renal tumors you know
of? The von Hippel-Lindau's disease and familial papillary renal cell carcinoma.
Okay, and
Cowden's syndrome can also have.
Okay, have you heard of tuberous sclerosis?
Yes, ma'am. They might have cafe au lait.
What are the cutaneous features of tuberous sclerosis?
They might have cafe au lait spots, I think.
Something more? Something very prominent on the face?
Hemangioma.
Adenoma, sebaceum.
Yes, ma'am.
Sjogren's patches. Cafe au lait spots. Okay, so you can read about it. Nothing necessary that you should know, but yeah, if somebody asks.
So what are the extra renal manifestations of a renal cell carcinoma?
They might have hepatic dysfunction causing jaundice, a non-metastatic hepatic dysfunction. They can also have polycythemia, and they can have hypertension, hypercalcemia, and they can also have so that's it. Pallor can be present. And
what is this due to?
The pallor is either because of reduction in production of erythropoietin, and if patient has polycythemia, at times few tumors, they can increase the production of erythropoietin, and that can lead to erythrocytosis and polycythemia and also polycythemia. Also, they might have hypercalcemia because that parathyroid hormone, the production, this production of PTH or PTH like related peptides, which can lead to hypercalcemia. Or if they have metastatic disease, then they can have hypercalcemia because of the osteolytic bone mets. And other thing.
And Stauffer syndrome is due to what?
Because of hepatic dysfunction. It's not because of metastasis. It's non-metastatic hepatic dysfunction because of some production, I think, of some interleukins. I'm not sure exactly. I forgot.
Okay. Before your exams, you better be sure.
Pujita,
Acha,
can I
yes.
ask you a question?
Yes, sir.
You have talked so much about the renal manifestation, extra renal manifestation. Would you like to put any differential diagnosis about your tumor? After examination, yes, agreed. The first diagnosis with all things pointing, it has to be that. But did you think of any differential diagnosis?
Sir, it could.
Yes.
I didn't think of any other.
So can it be a left suprarenal mass?
But it will hematuria would be unlikely, sir. If it's a
patient
if it is involving the kidney, there will be hematuria. It can present exactly in the same manner as a renal mass.
He did not have history. He did not have history of palpitations and sweating.
Is it necessary? How
Not
many
necessary.
percentage? Sorry,
I think
how
less
many
than
percentage
20.
are functional tumor and how many are non-functional tumor?
Functional tumor is a function. It's less around 10%, I think, sir.
So it may not be present.
So 90% are non-functional.
Yes, ma'am.
And why should it be a pheochromocytoma? Why can't it be an adrenal cell carcinoma, ACC? Adrenocortical carcinoma.
That would it would be rapidly progressive, and you would have had weight loss and.
But he has weight loss of 3 kgs.
3 kgs.
So you don't want to consider suprarenal?
We can consider, sir.
We can. You must.
You
Yes,
need
yes,
to consider.
Yes, sir. Yes.
What you know it, I know it, but it is not that you have to depend all the time.
Yes.
So there are points examiner can ask you. Patient is hypertensive. You have written 180/100.
Yes.
Whether it is a paroxysmal or not, whether it is because of your examination or we don't know.
Okay, sir.
Hematuria because of the uncontrolled hypertension. There may be directly involvement of that. So the point is, it is very difficult to differentiate large suprarenal from the renal upper pore of kidney. You have not done any investigation. You should not rule it out as far as I.
Okay, sir.
So it will be useful when you go to investigation.
Yes, sir.
So sure of this, only one diagnosis.
Okay. Yes, sir.
Always think of other things which are possible.
Yes.
I'm not saying it is like that, but it can be that. Any other thing? So in other words, what are the rare tumor which can happen in this area apart from renal?
Retroperitoneal sarcomas.
Yes.
And in.
Okay. So some retroperitoneal tumor should be considered. Okay. Please carry on.
Your tumor is bimanually palpable as well as ballotable.
Yes, sir.
Is that usually possible? The tumor can be either ballotable or it can be bimanually palpable.
If it is bimanual, if it's completely touching the anterior abdominal wall, it will be very well palpable bimanually, but we cannot do ballotment that time because there won't be space for it to move. But this was, I could palpate it only on deep palpation anterior, so I think there was some space to do the ballotability.
Sir is asking what is difference between bimanually palpable and ballotment?
Bimanually palpable is when we can feel the tumor both with the anterior abdominal wall, and also when we place the hand posteriorly, we can feel the tumor posteriorly also. And in ballotment, we might not be able to feel it. And ballotment is the movement of the tumor, and we give a thrust or pressure posteriorly, we'll feel the mass coming and hitting the hand anteriorly.
So which tumors are ballotable?
Anything arising from the kidney?
No.
Within the Gerota's fascia.
Tumors, forget about kidney. Which tumors are ballotable?
Ovarian tumors also can be ovarian.
Why they are ballotable?
Because because they have a narrow pedicle.
Yes, they are hanging on a pedicle. That should be the answer, right? So how do you elicit bimanual palpation? What is the maneuver you do to palpate bimanually any tumor in a renal area?
We have the patient is supine, sir, and then we place one hand posteriorly and one hand anteriorly, the posterior hand is within the renal angle and anteriorly is in the lumbar region, and then with sudden thrust forward with the posterior hand we have.
That is
Yes, sir.
ballotment. I am asking you bimanually.
So bimanually same, we'll place both our hands and we press both of them simultaneously to see if we can palpate them both.
And one more thing is always ask a patient to take
respiration.
Yes,
Take a
which
deep
is
breath.
mandatory.
Yes, sir.
When you cannot elicit ballotment in renal
And
tumor,
If it is if it's very large and already coming up till the anterior abdominal wall, or if it is gone beyond the gyrotous fascia and already and it's infiltrated and fixed, then we won't be able to elicit ballotment.
For the sake of postgraduates, I just want to good evening, Pankaj bhai. Namaskar. So,
sir, we meet again. Good evening.
Yeah, for the sake of postgraduates,
Yes, sir.
Sir, we teach internal ballotment and external ballotment. Number one, internal ballotment is the ovary, what you told just now, because ovary comes out of the pelvis with a pedicle. So, per vaginal examination one side and another push from above, especially one which has come out of the pelvic brim. So that is internal. Now, external ballotment, like what we teach is generally, there should be a sufficiently big mass. But it is too big means there is no place for it to go. So classically, the huge spleens and liver, large ascending colon masses, large masses. Sometimes you can get a even bimanual palpation because they are peripheral, but usually they are not ballotable. That's what we generally teach, sir. So,
yes, sir.
Professor Manap and Professor Atarza, ma'am.
So you can go ahead with whatever investigations you would like to know. Will somebody be telling you, or you yourself know the investigation?
So this patient, I have the investigations, ma'am. So this patient, he initially had gone to an outside hospital and he said he had undergone an ultrasound scan. So firstly, I would like to look at that report, the ultrasound report of the outside hospital, and also do a complete blood picture and renal function test here. So his blood investigations, hemoglobin was 8.4 and the rest of it was normal. Renal function tests were normal. The liver function tests were normal.
You don't do a urine routine micro?
And yes, ma'am, we do it, and that had shown microscopy showed RBCs and also sugars and proteins in blood was positive.
So what is the indication of positive proteins in this urine routine microscope?
So, ma'am, one thing he probably, because he's diabetic, he has some amount of proteinuria because of probably chronic kidney disease or diabetic nephropathy.
Okay.
Other thing, probably also because of the tumor, he has proteinuria.
Why? Why
Can
should the tumor cause proteinuria? So in renal tumor, the urine routine micro, RBCs or hematuria is also a protein. So they get detected as protein plus. So if the hematuria is gross, it can still be showing proteins as plus. Secondly, if there is renal vein thrombosis, it is one of the cause for proteinuria. And as you said, diabetes, long-standing diabetes could be associated with proteinuria because of renal damage. So these are the three possibilities why yes, proteinuria. Maybe you need to quantify the proteinuria because proteinuria is beyond 2 plus 3 plus in renal vein thrombosis.
Yes.
Okay, so do you do cytology for patients with hematuria, or that's not the protocol? Because I may be asking wrong questions, I think.
Cytology, because I'm not sure, ma'am, if they do it or not in urology here. It was not done for this patient.
Mm-hmm. Okay.
but it can be done.
Okay, suppose you had ordered it. Why would you order it?
We can, if there is any, usually cytology is positive for bladder neoplasms and also upper tract neoplasms. But if I'm not sure why we'll order it.
But your diagnosis is not an urothelial malignancy, right?
No, it's not. No.
Mm-hmm. Okay. Okay, we'll skip it. So what is the ultrasound report?
The ultrasound report of the outside hospital, the patient did not have it here.
Let me ask you a question. Suppose the patient did not have an ultrasound and he presented to you directly with hematuria and this history. Would you order an ultrasound or would you order a CT scan?
Ma'am, we can get a CT scan directly.
Okay, so you would get a CT scan directly, and may I know the reasons why?
Because on examination we can feel a renal mass, and if it is probably an renal mass and probably renal cell carcinoma, anyway we would be ordering a CT for prior to any operative procedure or further treatment. So we can directly, and he's stable and it's not, and we can just directly get a CT.
Mm-hmm. So what type of CT scan? Is there anything called a renal protocol?
Madam, can I interrupt you?
Sure, please.
I have something to say. Are you sure it is renal mass, Pujita?
No, sir.
Why you will straightway advise CT?
Clinically, she feels it's a renal mass.
But I will like to differ.
Yes. Then if we want to, we can get an ultrasound to see
No,
the origin of the mass.
I don't want anything.
We have to.
So the point is, you are lucky that this case is very clear, but still, I don't know about the other. I would like to go for ultrasonography in this patient before submitting patient for CT to have a baseline ideas, and you can decide whether patient need which kind of CT, or if there is some surprise, we can advise additional thing in CT. That's what my take is.
Probably there is no doubt about that you will not get the ultrasound. You know, ultrasound and extension of examination, you are not sure that what you're dealing. You may be dealing with a renal lump, but as Dr. Modi said, it was suprarenal. So you have to do ultrasound is much easier to do. Yes, within 5 minutes, the report is in front of you that what you are dealing with. And based on that, you decide that in what way you are going to proceed.
Yes.
So ultrasound has to be done. There is no doubt about that.
So just continuing it, is there a difference in protocol for renal tumors for CT and adrenal tumors, or the same CT scan is ordered?
For adrenal tumor, we can get an adrenal protocol CT with a thinner sliced cut.
Is it a thinner cut or is it something more?
Even the IV, the delayed phase after the contrast injection varies, ma'am, for adrenal.
Any specific term for adrenal?
Not sure.
Okay.
So if at all you're suspecting an adrenal tumor, you would ask for a percentage washout of the contrast for in an adrenal tumor. Okay. While in a renal tumor, what is the specific thing you would like to look at?
You would ask for a delayed phase and also CT urogram along with the CECT abdomen.
Okay. Would you order a CECT abdomen or CECT abdomen pelvis? And
CECT abdomen pelvis and also a thorax for metastatic workup. But first we can
is it that protocol for you all that you order chest, abdomen and pelvis? Or this is commonly practiced protocol, or
they get thorax also.
Okay, you have done a ultrasonography and there is a surprise. It shows it likely to be suprarenal. You will advise go straight away for CT?
We can do if it's the ultrasound is showing probability of a suprarenal mass, we can get we can do a 24-hour urine test to look for any metabolites, the catecholamine metabolites.
Yes. Anything else?
Do they do
And-
the urinary test nowadays?
Yes, ma'am. 24-hour. We do the HVA and VMA.
I think we differ. We don't do a urinary VMA, nor do we do urinary metanephrine. We do plasma-free metanephrine directly.
Yes, madam.
So we don't do both this urinary test now.
So why would you do it before going for CT?
We can, why before?
What can be the problem if it is a pheochromocytoma and you
If
advise
it is,
CT?
if it is a pheochromocytoma one, if while giving the IV contrast, you might have to be careful if patient. I'm not sure, sir. What is
So
the
the point
difference?
is that till now that might be a non-functioning or dormant, but it can activate it. So if you are suspecting suprarenal, you have to be extra careful, starting from examination to everything. That is one more argument for doing USG
Yes.
before anything else. Okay, please.
Okay, Pujita, in your CT scan, what would you look for?
I would like to see where the mass is coming from, if in the kidney, from which part of the kidney, the size of the mass in relation to the surrounding structures. Also would like to look at the vascular supply of the vasculature of the kidney, and if there's any thrombosis in the vein.
Look, most important is to know whether the other kidney is functioning.
And yes, right, kidney, it's
Because
normal.
that's the first thing you look for.
Okay.
Before you proceed for any other thing, right?
Yes, sir.
Okay, so do you have the CT scan report for this patient?
Have the films, sir.
So, okay, let's start with what's the stage of this patient, of this tumor then?
Clinically, it's about 8 centimeter mass. And so that will be T2, sir, if it is 8 cent, if it's more than 8 centimeter.
Okay. So, do you need a tissue diagnosis for this patient?
Not required, sir. If it's because if it is a renal tumor, if we do a percutaneous biopsy, the chance of tumor seeding in the percutaneous tract.
Why? And that's the only thing which is a contraindication.
And also we'll breach the Gerota's fascia.
So you'll make the tumor from
T2 to T4.
Right. Okay. So what are the indications for doing a tissue biopsy in case of renal cell carcinoma?
If we are not sure about the diagnosis, if there's any different, the findings on CT are not suggestive of renal cell carcinoma, and if it's a small tumor and we are planning for any of the newer any radio frequency ablation or cryotherapy, so you won't get tissue later on. So if you want to get a tissue before that, and if it's a large tumor, advanced, and we're not planning resection, to give palliative treatment to get a tissue diagnosis.
So that's the only reason. If you have a large tumor, you have to give palliative or any other treatment other than surgery, then it may not require a tissue diagnosis. Okay. What is the characteristic? There are some tumors which disappear on their own. Renal cell carcinoma is one of them. Right? Can you name any other tumors which disappear on their own?
Small melanomas can regress, sir. I think.
Any gonadal tumors, can they regress?
Yes. The dermoids can regress at times. Dermoid tumors.
Look, most common are retinoblastoma, neuroblastoma, and renal cell carcinoma. These are the ones which can disappear on their own. Right? Okay. So, what is the association of von Lippin? Okay, what is the pathological gross of renal cell carcinoma?
They'll have gross, sir. So they'll have areas of necrosis and hemorrhage and cystic degeneration within the tumor, and they might be it'll be
What's the characteristic color of this?
It's brown.
It's reddish yellow.
Okay, sir. Yes, sir.
With reddish is because of glycogen. So how is it related to von Hippel-Lindau syndrome?
If it's von Hippel-Lindau syndrome, there's a possibility of bilateral renal cell carcinomas. And
What is von Hippel-Lindau syndrome?
It's a defect in the chromosome 3 and the VHL gene. It's a familial tumor.
It's a glycogen storage disease. It's a glycogen storage disease. That's why you get glycogen in the tumor, and that stains red.
Yes.
Okay.
Can I ask a few questions? Pujita?
Yes, sir.
What is Robson staging?
What is?
Robson staging of renal.
So there are 4 stages, sir, in that. So stage 1 is when the tumor is only in the kidney. In stage 2, it extends up till the perinephric tissue, and in stage 3, it goes into the any of the venous system or venous thrombosis, and in stage 4, it goes beyond the Gerotus fascia and up to the it can also involve the adrenal glands.
See, there are 4 stages. Stage 1 is confined to the renal parenchyma. Stage 2 extends beyond the renal parenchyma but still confined by the Gerotus. And stage 3 is divided into A, B, C. And stage 3A is vascular involvement up to the right atrium, even up to the right atrium. 3B is regional nodes, and 3C is involvement of both. And 4A is infiltration of the adjacent structures, and 4B is distant metastasis.
Yes.
What is the role of MRI in evaluating the renal cell carcinoma?
Sir, if a CT shows a possibility of a thrombus, venous thrombosis, we'll have to get an MRI.
Yes. MRI gives a better picture up to the extent of thrombosis, extent of the thrombosis. One more question. I think it's beyond your limit. Anyway, I'll ask. What is bench nephrectomy?
What is?
Bench nephrectomy.
I'm not sure.
Okay.
Maybe partial I don't know, sir.
Bench nephrectomy actually in case of bilateral renal RCC or in a patient with a single kidney with RCC, they remove the kidney from the body.
Yes, and then they operate outside and do a auto transplantation.
Yes. And put it back inside.
Nephron sparing, that is nephron sparing nephrectomy. When there is a bilateral disease, you try to save as much kidney as is feasible. Otherwise, if you are not very careful enough, then either you might leave a gross tumor inside, or if you are or you might even cause non-functioning of kidney requiring a renal transplant. And if that is not, or a dialysis. So,
what is the role of immunotherapy in RCC?
Sir, in advanced disease or metastatic RCC, we can give immunotherapy.
What are all the immunotherapeutic agents?
The PD-L1 inhibitors, the pembrolizumab is there, and also we can give VEGF monoclonal antibodies.
Where else you can use immunotherapy apart from RCC?
We can use in melanoma.
Yes.
And we can immunotherapy also in metastatic, I think, colorectal cancers.
Bladders?
Yes.
Okay. Where we use BCGs. Okay. Yes, that's from me.
Pujita, clinically, how can you distinguish whether the renal lump is a malignant or a benign condition?
Hello.
Can you?
Hello.
No, sir, we can't definitely distinguish, because even malignant tumors can be firm with a smooth contour if it's within the Gerotus fascia. So we won't know if it is, unless it's fixed and this hard irregular surface, then it's more likely a malignant tumor.
Usually malignant tumors, the renal angle will be full, but in benign, it will not be full.
Okay, sir.
What are the benign other tumor swellings of the kidney? What
So
are the,
hydronephrosis or polycystic kidney disease.
in which condition you get bilateral hydronephrosis?
If bilateral PUG obstruction, or if there's any lower urinary tract obstruction, and if they have retroperitoneal tumors impinging on both the ureters.
So what is the age of usually this PUJ? We talk about.
Will be in younger patients, sir, younger females.
So if there's a bilateral hydronephrosis in an elderly man or a woman, what do you suspect?
If any bladder tumor can cause obstruction,
but no hematuria, nothing, not in
then
the urinary, not in the urinary tract, somewhere else, but but bilateral hydronephrosis.
Any lymph node impingement or fibrosis of the retroperitoneal fibrosis can also cause.
I said elderly. Remember, never forget rectum as well as cervix. Okay, cervix,
yes, sir.
Extension of the spread. Nowadays we are not seeing. So bilateral hydronephrosis, one of the differential diagnosis. You have images, sir, CT scan of this?
Sir.
Can you just put that so that we can, yeah, just.
Okay, Pujita, sorry.
Yes, sir.
How do you know this is a contrast? Is it a CCT or a plain CT? How do you know?
This is a so this is a contrast because the aorta is lighting up in this.
Very good. The aorta is lit up. It's a contrast.
It's contrast. It's arterial phase. So there is a large mass in this arising from the left kidney. Most probably, it looks like it's arising from the lower pole. It is heterogeneous, and there are areas of different. It's a heterogeneous mass, and in this, the right kidney appears normal with good contrast opacification, and in these films, yes. So it's predominantly a lower arising from the lower pole, and it's reaching the abdominal wall laterally, and anteriorly is displacing the bowel loops, and the bladder is normal. This is the mass.
While describing a renal mass, you should start with size.
Yes,
shape,
this was
position, extent, whether it is medially situated or it is towards the cortex and the outer surface, whether it is mainly intrarenal, mainly extrarenal, because the renal scoring system takes all these things into account, whether it's towards the hilum and whether it is heterogeneous, whether there is calcification, AV malformation, increased vascularity, how many Hounsfield units it has enhanced by. Then you go stage by stage, whether it's involving the gerota, whether it's involving the psoas muscle, the abdominal wall, adjacent structures, lymph nodes, renal vein, and IVC.
Yes.
Okay, so if you go systematically, it gives a very nice impression.
Oh, yeah. This seems to be arising from the lower pole of left kidney. It seems to be exophytic, and it's around almost 11 into 10 centimeter in size when I measured. It's heterogeneous, and it seems to be within. It's not beyond the gerota's fascia. It's well within it, and there is the tumor seems to be vascular because the areas of vascularity in between, and the IVC can be seen. Here, there's no thrombus within the IVC.
And renal vein?
And renal vein, I'm not sure if it's seen in these cuts. It was not there, ma'am.
Okay.
So
then
this is the size of that.
Node?
And
Where
few
will you look for lymph nodes?
Lymph nodes we'll see in the perirenal and para-aortic also. We have to look for. With near the hilum, if anything is there, and if around near the para-aortic.
And from what extent will you look from? Above downwards?
From the crux of the diaphragm up till the bifurcation of aorta, we have to look for lymph nodes.
On the left side, it is slightly higher up. On the right side, yes, till the bifurcation and common iliac bifurcation of the aorta. On the right, on the left, it can go up to the level where the inferior mesenteric takes off.
Okay. Yes, ma'am.
And right and left, there are differences. I hope you know that. into the different groups where they drain commonly into. So one more thing is try and mention whether the tumor is confined to the lower pole or middle pole or upper pole, whether it's encroaching on the hilum.
Yes.
Okay. And do mention characteristics, whether there are areas of necrosis, hemorrhage, specification, AV malformation, increased vascularity, all these things, if you mention, it creates a nice picture.
If you have to do the CT for a stone disease, what type of the CT you will do?
Plain CT, sir.
You do always plain CT first. Okay, now tell what are the various gross differences between a Wilms tumor and a renal cell carcinoma?
In the renal cell carcinoma, it's within the Gerota's fascia. It does not breach it immediately. And in Wilms tumor, it can go beyond the fascia, beyond the Gerota's fascia. And there will be a lot of areas of necrosis and hemorrhage in renal cell carcinoma. And Wilms tumor is more of a solid tumor, I think. And
More yellowish. There is a pseudo capsule formation in the Wilms tumor, and it looks all smooth. Now, just like a seminoma, the testis is the similar appearance of the Wilms tumor. While in the renal cell carcinoma, you get the variegated appearance,
irregular, yes,
which is like a teratoma of the testes. Okay, you get the variegated appearance there. Now, tell if the patient has got a uncontrolled hematuria, and this is not a resectable tumor, what are the possibilities for this patient? How can we stop the hematuria?
If it is uncontrollable hematuria, then we have to see if it's one vessel that is bleeding into CT angio, and we can probably embolize that vessel.
You do not have the facility for the embolization.
Then we'll have to do a debulking surgery too.
It is so extensive tumor that you will kill the patient on the table.
So radiotherapy can be given, I think. I'm not sure.
Simply ligate the ureter away from the tumor. Okay, so there will be a tamponade effect will be there. So that's the simplest thing which you can do, and probably it will control. It may not control in every case, but because the tamponade effect which is there, it may control the hematuria.
Yes, sir.
I think one more common question is, will you do a biopsy in this patient to confirm the diagnosis?
No, sir. We don't have to do a biopsy.
So if there's a clinical, the radiological, the all findings match, no indication to do a biopsy.
Yes,
so
what did you plan for this patient?
So we'll have to plan a radical nephrectomy for this patient. Hello.
What is the meaning of the radical nephrectomy?
So in radical nephrectomy, we remove the entire kidney along with the Gerota's fascia, the ipsilateral adrenal, and also the enlarged lymph nodes in the territory of the tumor, and if any enlarged para-aortic nodes are there, we'll have to do a lymphadenectomy of that also.
Pujita,
And
how
the
does your
proximal third
surgery?
of the
How does the surgery for RCC, radical nephrectomy, differ from transitional cell carcinoma?
For renal cell carcinoma, we remove only the proximal third of the ureter, sir. But in transitional cell, we'll have to do a nephrouretectomy. The entire ureter up till the insertion in the bladder, along with the intramural part of the ureter, should be removed in transitional cell carcinoma of the upper.
You have to remove cuff of the bladder.
Yes. Sir, I didn't hear you.
Want to do a radical nephrectomy in this patient, what approach you are going to follow?
So we will we'll give a subcostal incision laterally, and we'll go retroperitoneally.
Renal carcinoma, you go intraperitoneal approach, or what is your first aim?
First aim to get to remove all the tumor and along and even the lymph nodes to get a negative margin.
No, no, no. Sir is asking, when you are doing a radical nephrectomy, what will be your first concern? What will happen? You manipulate the tumor early.
If we manipulate the tumor, there can be embolization of the tumor into the circulation. So we'll have to make sure the vascular pedicle is
Pedicle means?
the artery and the vein is
So
that.
what will you tackle first, vein or artery?
The artery is ligated first, sir.
What is anterior?
The
Relation?
vein is anterior.
The vein is anterior. And usually vein is tackled first. At least if you do not ligate, it's tackled first, followed
Yes.
by artery. The another question is that what will happen? You put a posterior approach, what you were talking, subcostal. What is the size of this tumor?
It's 11
So
centimeters.
do you think it will be easy to tackle from
Difficult.
that?
No, sir.
So what is the standard procedure?
Then we'll have to,
A malignant tumor.
we'll do transperitoneal only.
Usually the people prefer transperitoneal, incision may be midline. That is the usual way. Is there any role of preoperative embolization if it is available?
Sir, not really. So it doesn't reduce the size of the tumor. They say it's not required.
Most of the time it is not.
And what trouble can it cause? Can it cause some problems? In case you wish to embolize, then within how many hours or days should the tumor be operated?
Ma'am, I think within 24 hours. I'm not sure. I think 24 hours.
Preferably at an earlier date. Why? Are you very right in saying so? Why?
Because if it once the blood supply goes to become necrosis and might get infected, maybe.
It becomes too edematous and too difficult a dissection. It becomes all swollen around, right?
So plane of dissection goes away unless there is a specific reason. Most of the time it is not, unless there are some specific cases like that where it is tackling will be very difficult or not possible to manage. Most of the time it is not done. So not in this context, is there any role of partial nephrectomy?
If it is a small tumor, we can consider.
How much small? How much
less
small?
than 4 centimeters.
And one is that, and
if it's a only single functioning kidney, if he has bilateral.
No. Even in a both functioning kidney, there is a
bilateral tumors, bilateral renal tumor.
In a single, no, don't say that bilateral tumor. Renal or kidney preserving surgery is a definitely
yes, sir.
Even if it is a bilateral, not bilateral, in a single kidney, then we don't have an option. But even if it is only one side, what are the indication of doing partial nephrectomy?
If it's in the lower pole, less than 4 centimeters, and young patient
or upper pole.
Yes, sir. And young patient, and also if it's because of any of the genetic disease, VHL, they have a risk of recurrence and multicentric disease. So if we can do partial nephrectomy in that.
So Pujita, for the first answer for renal artery embolization, that it can be done in intractable cases of hematuria to just gain some time to reach or to operate the tumor and stabilize the patient.
Okay,
the problem about embolization is it can cause septic syndrome. So in if you delay the nephrectomy beyond 48 hours after embolization, there is septic syndrome sort of feature which develops in this patient. And hence they should be operated within 48 hours or within 24 hours. It does cause a reduction in the size of the IVC thrombus, but it's not where it's something dramatic and therefore it's given up.
Yes,
because but in very large tumors where you are not able to get control of the renal artery first, it may be still an useful maneuver. Then considering nephron sparing surgery, you rightly said that it is used for tumors less than 4 centimeters, but here you need to read about the nephrometic score. Okay,
Yes.
So tumors which are medially placed, suppose it's a 2 centimeter tumor which is placed in the hilum. It will be difficult, right?
Yes, ma'am.
Compared to a 2 centimeters
Lower
tumor
pole.
situated at the lower pole or in the middle pole or in the upper pole. So nephron sparing surgery is usually considered for tumors less than 4 centimeters. However, now the indications have been extended up to 7 centimeters, provided it's not encroaching on the major vessels, it's not involving the PC system, and when there is some benefit of preserving renal parenchyma. Suppose it's a 7 centimeter tumor in a 70-year-old male who has an opposite normal kidney. There's no point in doing a nephron sparing surgery for him. So you understand?
Yes, ma'am.
Yeah, so your answer should be tailored that way whenever they ask you what are the indications for nephron sparing surgery.
Yes,
So
ma'am.
if the patient has an opposite totally normal kidney, then definitely a large tumor like 7 centimeter tumor won't be a indication for nephron sparing surgery. But at the same time, suppose it is a patient with bilateral tumors which are peripheral in size, and then you will be, if you are able to get away without involving when there is no involvement of the renal artery, vein or the PC system in a major way, then it is possible to do a bilateral nephron sparing surgery.
Yes, ma'am.
Okay, yeah, but I think you need to read little more on it. You need to know all the various scoring systems. There are 4 or 5 scoring systems which tell you the basis for whether you can do a renal nephron sparing surgery or not. There are polar lines for the kidney, so it depends on where the tumor falls in, whether it's within the polar lines, outside the polar lines. So there are many things to it. Okay, so I think that part you can read definitely. It will be a scoring point for you if you can answer these questions.
Any other faculty you would like to add up? Rajgopal sir, Kanna sir.
I don't want
Yeah,
to
ma'am.
add anything new to what Dr. Sujata madam has given.
No, nothing like that, sir. You can please add. Go ahead.
It is one thing good is that it is a complete refreshing for Dr. Pujita or this exam going batch, one who are appearing next month exam. So that's the reason why I last moment also I told her to come. Doesn't matter. There will be some questions. We also do not know many questions, many answers. So let us. It's a knowledge sharing platform. So very well discussed. That's what I want your comments on my candidate PG. That's all.
Sir, she is really good. Only thing is we have not discussed is the role of laparoscopy. That is also she has to read up because some examiner is bound to.
Yeah, they're bound to ask you because laparoscopy can be done retroperitoneally, but it's usually done transperitoneally. And there would be nowadays there are people who are doing laparoscopy even for IVC thrombus and even IVC thrombus going up to the right atrium.
Yeah.
It can be done. Dr. Inder Birgil has videos and he has many presentations on it.
They are very fond of. So you are supposed to know.
Yeah.
That's it. Okay. Thank you, madam. Sir, it was
Thank
a good
you.
discussion.
Thank you very much. May I leave the meeting now?
Madam, 1 second. Pujita, do you have any questions to be clarified with all the eminent faculty here? Do you have any doubts to be clarified?
No, sir. I have learned a lot.
Thank you, Dr. Pujita. And with the permission of the faculty, we call this case to come to a close. Sujata ma'am, we are moving to the right leg fossa mass case.
Yeah, thank you very much for including me, and it was really nice to talk to all of you, Dr. Ajay Khanna, Dr. Pankaj, and Dr. I could not see many people, but Dr. Rajiv and whoever I'm seeing on the screen, Dr. Ganguly, and yeah, many of them. So thank you very much for including me, and it's a pleasure being part here. Thank you very much, and bye.
Thank you, ma'am. Thank you so much.
Bye.
So with that, we thank Madam and we thank Dr. Pujita for joining us. Now we move on to the next case. Dr.
Can I make a small comment?
Please, Madam. Sorry. I thought you are done.
I think the girl is brilliant. The only thing is that she was telling some nice points. For example, she clearly mentioned that the history, one could make out that it was a varicocele. but when somebody interjected, she just kept mum. So I think what she should do is that she should stand her ground. She should say, look, madam, I had said this. So that amount of courage is necessary. Otherwise, I think well presented, you have read the subject well. It is just that you get a little bossed over by at times, right?
Yeah, true that. I support that. I really support that. Yes, true. You'll have to stand your guard.
Madam,
Yes,
as long
you'll
as
have to
they are
stand your ground.
student, they need some safety measures in place, madam. That is otherwise, I'm sure she is confident.
It takes a lot of guts. It takes a lot of guts to stand up. I mean, really, as a student against a professor, it takes a lot of guts.
Sir,
But you will have to.
Sir.
Again, you will pass with wrong diagnosis if you can stand your ground.
Our MS time, we did not have any voice to actually speak against the professor or something. But modern day, I'm not trying to say that you really contract but some reference if you can give, it is not all that bad. The times have changed, sir. Times have changed. So the definite change is there.
But she presented very well.
Sir, whole idea is postgraduates get a good chance to face so many examiners from all over India. All over India, sir. This is the opportunity for them.
Sir, can I add something?
Sir, yes.
Yes, it is good. She should have a guts to stand up. On the other hand, she should be open also. That is the one thing I would like to again remind her, that do not restrict yourself to one diagnosis.
True.
If some examiner is giving you hint, take that hint. That is all cases will not be clear cut like this.
Yes. Thank you, sir.
Good. Well done.
Now we move on to next case. Dr. Vimal, please introduce yourself and share your presentation and start your talk.
Yes, sir. Thank you very much, sir.
Good luck to you.
Yes.
Good luck.
Thank you, sir. Myself, Dr. Renal Majumdar, second year postgraduate training in general surgery at Jorhat Medical College and Hospital. I thank my HOD sir, Dr. Atul Guru sir, who is my head of the department, and Dr. Ganguly sir, and also Dr. Manu sir for giving me the opportunity for presenting the case in today's.
Vimal, could you speak a bit slowly and loudly? Yeah, you're not very audible.
Yes, sir.
Can you remove your headset? Maybe that is making the things unclear, because when we started the trial, you are okay. If you can remove the headset from your computer also.
Am I audible now, sir?
Yes.
Much better. Go slow. That's what Sahai sir is trying.
Very good.
Okay.
Please share your PowerPoint and start the presentation.
Thank you very much, sir. Myself, Dr. Bimal Majumdar, second year postgraduate trainee in general surgery at Jorhat Medical College and Hospital. My HOD is Dr. Atul Guru sir, and I thank Dr. Ganguly sir and Dr. Manav Bhai sir for providing me the opportunity for presenting the case on this platform. I would like to share the screen, sir.
Please go ahead.
Thank you, sir. So the case which I was supposed to present was a case of heart in the right iliac fossa. I shall start now.
Please
start.
Yes. Now, the patient was Miss CS, aged about 60 years, female, resident of Doria Tea Estate, district Golaghat, in the state of Assam. By occupation, she was a shopkeeper, and she was admitted on 15th of February 2021 and was examined by me on 24th of February 2021. She presented with the chief complaints of pain over right lower abdomen since 2 months and swelling over right lower abdomen since 2 months. History of present illness. The patient complains of pain over the right lower abdomen since 2 months. It was insidious in onset and continuous dull aching in nature. There is no relationship to food intake and no aggravating or relieving factor. There is no history of vomiting. There is no radiation or shifting of pain to any other part of the abdomen. The patient also noticed a swelling in the right lower abdomen since 2 months. It was accidentally noticed by the patient 2 months back while lying down in bed. Initially, it was the size of a marble. However, now it has increased to the size of a tennis ball. There is no history of fever, jaundice, hematemesis, or hematuria. There is no history of passage of black stools or fresh blood or mucus in stool. The patient has normal bowel and bladder habits. She passes stool once a day and passes urine 3 to 4 times a day. The patient doesn't give history of weight loss. She gives history of anorexia since admission. Her sleep was normal. Now, past history. No similar history is given by the patient in the past. The patient has no history of diabetic mellitus, jaundice, asthma in the past. The patient is a newly diagnosed case of hypertension after admission to Jorhat Medical College and Hospital and is on medication, tab amlodipine 5 mg. The patient gives history of pulmonary tuberculosis 13 years back, for which she took 6 months anti-tubercular therapy course in her local hospital. She has 3 sons through normal vaginal delivery. There is no history of abortion or stillbirth. The patient underwent sterilization 13 years back after her last son's birth. And the family history, the patient is married since 30 years and lives with her husband and 3 sons, 2 daughter-in-law, mother-in-law, and 1 grandson. The patient says that her husband was suffering from cough for 4 weeks in the month of May 2020, and he was diagnosed as a case of pulmonary tuberculosis in her local government hospital. He was advised DOTS course under RNTCP. However, he is a defaulter. Rest all family members are enjoying good health. No history of similar illness is given by her for her other family members. Her mother died 2 months after her birth. Now, regarding her socioeconomic status, the patient lives in a kacha house and has a kacha latrine in the house. They drink filtered water. The family can afford 2 whole meals a day. Now, in her personal history diet, she consumes non-veg diet and she chews tobacco. Menstrual history, the patient attained menarche at 12 years of age and has not attained menopause. Menstrual cycle is of 28 plus minus 2 days with 4 to 5 days of flow. Her last menstrual period was on 2nd of February 2021. Treatment history, the patient has sought medical treatment for her condition from her local hospital until now. She occasionally takes non-steroidal anti-inflammatory drugs. Immunization history, it's not known. However, BCG scar was seen. She is not allergic to any currently used drugs by her or food eaten. Now, coming to the physical examination.
Hang on, Vimal.
Yes, sir.
Yes, we like to. Look, Vimal, your history is very long-winded. It's like an MBBS history. We want you to give us a postgraduate. What is the difference between social history and family history? Is there any difference between social history and family history? You seem to have mixed up both the thing together and put it in family history. I mean, Shirley living with her mother-in-law or daughter-in-laws is not family history, isn't it? Family history is what relates this disease to other diseases, other family members who have the same disease, right? Social history is what we see, that the kind of social support she will have if she has to undergo any treatment. So that's where her daughter-in-laws and mother-in-laws and father-in-laws come in, right? Also, immunization history is generally meant for children. It's not meant for adults. We don't ask, have you been immunized or not? Does it serve your purpose? It doesn't, right? So don't take the whole history from the book. You have to be a surgeon and present a history like a surgeon. Okay. So what do you think you're dealing with? Could you summarize the history? Could you summarize the history, please?
Yes, sir. So the patient, she presented with lower abdominal pain for a
Just
period
go back. Go back, slide back. Look, it is always best to summarize a history in a few words towards the end. We may have missed a lot of things because it's going on and on. My attention was going from here to there. So you have to bring my attention back to the relevant points, right? So try and summarize the history now.
Go to the first slide. Go to the first slide, Vimal, please. Second slide, next slide. So you have described that, don't do this, that reached up to tennis ball. It is for you to tell what is the present size. And this is actually whether you should do it or that marble size, tennis size, that is a little controversial, I would believe. But at the most, when the patient first notice, what about the present size? You are going to tell us what is the present size. You can write down reached up to present size. Similarly, next, that you have taken history of so many things, right? But as the sir has said, you have missed everything. That here you have written patient has a normal bowel and bladder habit. How does it come in a present illness? History of present illness. That is a personal history actually. It does not come in ODP. So there are certain, I have just pointed 1 or 2 points. There are so many of them. So learn to be precise and highlight the important point as sir has said. Please go to summary, and you have not written summary. That is the biggest problem. Please.
Now, the summary for the case was, the 60-year female presented with pain and swelling over right lower abdomen since 2 months. The lump is gradually increasing in size for the last 2 months. Patient doesn't complain of alteration of bowel habit. Patient passes stool once a day and doesn't pass any blood or mucus in stool. No urinary symptoms and no other systemic complaints were there.
What is the difference between the since and for?
Pardon, sir?
What is the difference between a since and for?
I couldn't get you, sir.
So is asking, what do you mean by since? And what do you mean by for so many days and since so many days? Is there a difference between the two?
Since when we mention something which has been continuing for a period of which has been continuing over a period, and the patient is presenting to us with that kind of a history, so we have to mention the duration. So we use since for the past.
And what do you mean for so many days? Look, since is when you know the definite date or a relatively definite date, right? So since last month, since like that 1 year, and for 1 year we're not very sure for so many years, okay, like that.
Now, should I move forward, sir?
So, Professor Khanna, anything else?
Apart from this, she didn't present with anything else. The summary was, as mentioned, she presented with pain for the last 2 months over the right lower abdomen, and lump which was gradually increasing in size for the period for last 2 months.
She's got pain and she's got lump for 2 months. That's it. Nothing else.
Nothing else.
Okay, go on.
Okay.
And you know, in summary, like you are writing so many lines there, it is not required. Summary doesn't have usually any negative history. Negative history is only when it is really positive one. You want to give a message that this is not there. Okay, if the bowel habits are normal, it is normal. It doesn't make any difference here. So when you're writing a summary, it has to be just that there is a pain and the lump in the abdomen for 2 months or whatever the time it is. Okay.
So on physical examination, on general examination, her mental state, she was conscious, alert, and cooperative. Build was asthenic, skin was normal. However, graying of frontal hair was seen and polyonychia was absent. Her teeth and gum were tobacco stained. Her body mass index was 22.2. Performance status on Karnofsky's grade, it was 100. And on ECG grade, it was 0. Hydration was maintained. There was no pallor, no icterus, no sinuses, no clubbing, no edema. Neck veins were not engorged, and no cervical lymph nodes were palpable. Pulse was 88 beats per minute, and BP, her blood pressure was 140 systolic, mm of mercury and 90 diastolic mm of mercury. Her respiratory rate was 18 per minute and temperature was at the time of examination 98.5 degrees Fahrenheit. Now her respiratory system on examination, it was within normal limit. Cardiovascular system examination was within normal limit, and her CNS examination GCS was 15 by 15 and it was within normal limit. On examination of the abdomen, on inspection, the shape of the abdomen was normal. Umbilicus was central in position and inverted. Movements of the abdomen was abdominal thoracic in type, and a surgical scar was seen near the umbilicus. There was no pigmentation or venous engorgements seen. Hernial sites were intact and her external genitalia was normal.
Genitalia.
On palpation, on superficial palpation, her local temperature was normal. There was no tenderness. There was no muscle guarding or rigidity, and a swelling was felt over the right iliac fossa. It was firm and non-tender. On deep palpation, lump was present just above and lateral to the McBurney's point, and liver, spleen, and kidneys were not palpable. On deep palpation of the swelling, the lump is globular in shape, 6 cm by 4 cm in size, surface is smooth, margins are rounded, and consistency is firm. The lump is intra-abdominal as is ascertained by leg raising test. There is no mobility with respiration. The lump is slightly mobile from side to side and up and down and is tender. Fluid thrill was absent. On percussion, general note of the abdomen was tympanic. There was no shifting dullness, and upper border of river dullness was at the 5th intercostal space, and percussion over the renal angle on both sides, it yielded a dull note. On auscultation, normal peristaltic bowel sounds were heard. There was no added sound. On digital rectal examination, a firm to hard mass was felt through the anterior abdominal wall. It was not fixed to the rectal wall. Gloved finger is stool stained. Pervaginal examination was not done. Now, this was a summary of the case. This 60-year female presented with pain and swelling over the right lower abdomen since 2 months. The lump is gradually increasing in size for last 2 months. Patient passes stool once a day and doesn't pass any blood or mucus in stool. No urinary symptoms and no other systemic complaints were there.
Oh, Vimal.
Yes, sir.
First of all, your summary is just a summary of your history, so it's not a summary of your examination, right? So that's out. You said Karnofsky's 100. Karnofsky's 100 is someone who doesn't visit the hospital. To visit the hospital comes down to 90, right? She's got a complaint, comes down to 90. You said you saw a surgical scar.
Yes.
Nothing, you said defined nothing about the scar. What kind of scar? I'm still wondering whether it was a laparotomy scar or it was a tubectomy scar.
It was a tubectomy scar, sir.
So you have to describe it. You've been describing, you described in deep palpation, described the lump. You went back to liver and spleen, then you went back to the lump. Also fluid thrill. Why should you do a fluid thrill when the abdomen is a normal shape? When will you get a fluid thrill? When it's distended, right? So these are very basic mistakes which I don't expect from a postgrad, right? So please take over.
And especially when you yourself said that you are able to see the lump very clearly, it is very distinct, having distinct margins. That means probably the fluid, even if it is present, it is of a very small amount. And a thrill is present only when the abdomen, the peritoneal fluid. And when it is lesser in amount, it can be shifting dullness or a puddle sign, or at times you can, it might go clinically undetected as well.
Fluid thrill is for a grossly distended large ascites. It is the last thing you need.
Yeah.
You have written that in superficial palpable, you have said that liver, spleen or not palpable. I think you have written, just go back. I wanted to reconfirm. Yes. Okay, so I think you have written in liver, but you said something about in superficial palpation about them. You have written swelling felt over right iliac fossa. What do you mean by that?
Sir, swelling was felt on superficial palpation. I could feel a swelling over the right iliac fossa region. So it was present there.
What is that? What do you mean by that? Superficial palpation is different than deep palpation when the lump comes. Why these two different things? So it should not be like that. There is no compartment like that for lump. That superficial palpation is one part, and that is described lump comprehensively. That this is the lump, and it is from this, right? Rather, I would like to say, if at all, you should be say whether the lump is intra-abdominal or not. That is the you created. I think you are talking about the lump which is present in a wall, something like that. When you say lump in a superficial palpation, I was misguided. It may be lump in the or a swelling in the wall and not intra-abdominal. Have you done that test? Is the lump intra-abdominal?
So it was intra-abdominal. So the lump.
How did you confirm that?
Pardon, sir?
How did you which test did you do to confirm that the lump was intra-abdominal?
So the leg raising test was done, sir.
It was done?
Yes, sir.
So is it a part of superficial palpation or a deep palpation? Again, it is that in undergraduate you did this, that's all right. You should be concentrating on this well-defined lump itself. Please continue.
Yes.
Again, I think we should say, as Naib said, your summary should not have the negatives when it is but obvious that only positives need to be put in the summary. That is what I think all of us believe in.
Okay, Vimal, what do you think is your differential here now?
Pardon, sir?
What is the differential here in this patient? What do you think is the lump?
Sir, since the lump is arising from the right iliac fossa, the structures which are nearest to and the structures located in the right iliac fossa would present with a mass or a lump in the right iliac fossa. So it could be based on the history, it could either be a cecal mass, or it could be tubovarian mass, or it could be due to appendicular mass, or it could be due to Crohn's disease also, sir.
Crohn's disease with normal. Look, you can't just give us a list. You did a rectal examination. You said there's something, you felt something hard anterior. What was that?
Yes, sir. Sir, actually, on rectal examination, the the firm mass which I felt through the anterior abdominal wall, through the anterior rectal wall, it was not fixed to the rectal wall. So it may be probably arising from the cervix itself, sir.
So you felt the cervix?
Yes, sir.
Right. So you say that. Cervix. Don't say I felt. You, of course, you can distinguish the cervix from a mass, can't you?
Yes, sir.
Right. So be precise. Just say that you felt the cervix. Rather than you thrown us everyone out of track by saying that there's a mass anterior to the perirectal. Now I'm wondering what is that now?
I thought it is small bowel.
So it was a cervix.
Okay. Have you examined the back of the patient?
Yes, sir, I did examine the back.
The spine.
Yes, sir. Spinal examination was there. There was no gibbous or the spine examination was normal, sir. I could feel only the vertebral bodies.
Did you examine the attitude of the lower limb?
Yes, sir. The attitude. The patient was ambulatory, and she was apart from her abdominal complaints, there were no any significant.
So you have to mention that. You have to mention that the hip movement is normal and the attitude of the lower limb is normal.
Yes.
Right? Why do you want to do that?
Sir, in order to since it can be right iliac fossa mass can also present as a in ileocecal tuberculosis. it can be presented as a right iliac fossa mass. So associated
A source
tuberculosis.
abscess. A source abscess will present as a right iliac fossa.
Yeah, so
Can present and that right.
Yes, sir. It can present.
Okay, so now what's the differential? You said.
So you can have
Please, ma'am.
as it is what Sir was trying to point out is that there's a family history of tuberculosis.
Yes,
the husband is probably suffering from it, you said, na? So
yes,
the
ma'am.
lady could also be having possibility of tuberculosis. It can
Yes,
present as a psoas sepsis. It can present as a ileocecal hypoplastic tuberculosis as well. It could even be a tubercular ileitis, right? So these are the possibilities that one should keep in mind. So what is the most likely? Of course, a carcinoma colon at times cannot be differentiated from a tubercular mass. So, or even an ANGOVA. So, what is the most probable diagnosis of this lady considering her age, her environment, her socio-economic strata?
Looking primarily at the history, since there is a strong past history that she had past history of tuberculosis around 13 years back, and there is a positive exposure history that her husband is a case of pulmonary tuberculosis, who is a defaulter. She may have had, she may be presenting to us with ileocecal tuberculosis, ma'am, as a right iliac fossa mass, based on the history, ma'am.
So what are the points against in your examination against tuberculosis?
Sir, against, I would say that apart from the very strong clinical history which she gave, that she was
No, examination.
On examination, sir. On examination, there was no, I couldn't find any abdominal lymphadenopathy, or there was no matting of lymph nodes, sir. There was no matting.
No, sorry. How would you find matting in clinical
matted lymph nodes or Dowie?
Excuse me, Dr. Vimal. I am asking you, how will you find out matted lymph node in clinical examination? It's not
of the abdomen. That doesn't make sense.
People don't get very hassled. Just cool down. Just relax. Okay. Just think. Just think about what.
Look at the slide I am seeing. Look at the slide I am seeing. Just read it and you will find the answer.
So first of all, the site of the lump, right iliac fossa.
So if there is a lump in right iliac fossa, what will you consider? Malignancy or tuberculosis?
So it can be both malignant and it can, but here since the history is there, we can consider about tuberculosis, sir.
What is normal presentation of tuberculous mass, ileocecal tuberculosis?
Ileocecal tuberculosis, sir, the patient may present with, as said, right iliac fossa mass. The patient can complain of swelling over the right iliac fossa. The patient will present with constitutional symptoms like fever.
No. We stick to examination.
Restricted to examination.
So suppose a patient has a ileocecal tuberculosis, what will be the pathological changes?
In the pathological changes, sir, the patient, if it is a case of ulcerative, if we consider it as a case of ulcerative tuberculosis, the patient may present with.
Okay, let me ask you a different way. You are not getting, or I am not able to convey it to you. What is cicatrization? What is
make a small comment? Sir,
yes, sir. Yes, madam.
Sir, can I make a small comment?
Yes, please.
Ulcerative tuberculosis present as a mass? Huh? Or is it hyperplastic tuberculosis which presents as a mass?
Hyperplastic tuberculosis is present as a mass.
So,
what is cicatrization?
Cicatrization.
What is pulled up cecum?
Pulled up cecum, we see it in a case of ileocecal tuberculosis, where the cecum, it is normally in barium X-ray and follow through.
Examination. What will you find in examination if there is a pulled up cecum in ileocecal tuberculosis?
The cecum will be felt higher up, sir.
Yes. Now you get it. So if you find commonly such a well-defined globular mass in a right iliac fossa, Would you like to put a tuberculosis first possibility or malignancy first possibility?
Sir, since if the cecum is felt high up, so tuberculosis has to be put up first, sir.
Okay, I give up. You have also written there is no mobility of lump with respiration. What do you mean by that?
Sir, in very few rare cases, if any structure which comes down up to the right iliac fossa, either an enlarged liver or with an enlarged gallbladder, so it may present with movement with respiration. Or, sir, in retroperitoneal structures, if a renal mass can also present with movement with respiration, sir.
Okay, upper margin was felt or not?
I'd like to make a small comment.
Yeah.
It is only those lumps which are related to the diaphragm, either directly or indirectly, that move with respiration. When you are saying that you are clinically able to clearly delineate it away from the diaphragm, you are able to palpate the upper limit, then I think beta, you should never say that it is moving with respiration. That doesn't sound great.
One more point. What do you mean by it is tender?
Sir, tenderness is something which the clinician elicits, and
what is significance of that? Dr. Sahai sir asked for that reason only. You have written it is tender. What does it signify?
It is any inflammatory mass can present with
No, your case. This is your patient. I'm not asking generally, and you say your patient lump is tender. What does it mean to you? Will you find any inference with that or not? Will it help to reach the diagnosis? Which lump in right iliac fossa are tender?
So, an appendicular abscess can be tender, sir.
Okay.
And tubo-ovarian mass can be tender, sir.
Okay.
Which doesn't
okay.
And
can an appendicular abscess have a history of 2 months?
Pardon,
you
ma'am?
were saying your patient. You said your patient had a lump for 2 months. So can you have an appendicular abscess for 2 months?
No, ma'am. Actually, appendicular abscess is generally
whenever you are talking.
Ma'am,
So
can I reply, ma'am?
Let me finish. Whenever you are talking of a particular finding in a particular patient, you must say that this finding in relationship to that. You should not give a DD of these such and such thing. She's having a chronic lump, having a history of 2 months. If it is tender, it is unlikely to be because of an appendicular lump or an appendicular abscess. Then, of course, it may be also associated with fever, and fever having spikes and chills may be present in abscess. So you're not having that kind of history beta, so it doesn't sound great. So please do not make these comments which might not go down well with the examiner, right? So please don't make a DD of an appendicular abscess in a lady who has had a lump for 2 months without any treatment.
The point is, madam want to tell you, even I was pointing at that. In a books, everywhere it is the first thing you examine is a temperature and tenderness. You have completely examined whole lump, and at the last, as a second thought, you are writing down it is tender. That is not proper. Tenderness is not something that you just throw it, because it makes a lot of difference. So it is very important. If it is a tender, it is tender from beginning. And if it is tender, you cannot go for a finality of the lump, what it is there. Because the tenderness will not allow patient will not allow you to examine it properly. Second point is, do not throw that appendicular abscess, which is a true acute condition. If at all you say appendicular lump, again 2 months is too long. Phlegmon, those are the things, not the abscess. Abscess is a really acute condition, and that patient will never come in your exam. You understand? So you first take together your act. Proper description is very important, and the books should be followed in that condition. that there is no elevated temperature, the lump is not tender, and these are the specification. When you say it is a globular 6 centimeter, there is no question of movement with respiration. It should not be done that. Theoretically, there are so many things which are possible. Theoretically, you may be right, but it is not proper. You will be in a trouble in that circumstances. That means you want to differentiate gallbladder swelling. That's what it looks like from this. Do you understand? It is not like that. Second point is that when you describe, understand the difference between right iliac fossa, right lumbar region, and right hypochondrium. You have stuck to the right iliac fossa. If there would have been a patient, I would like to see whether actually in a right iliac fossa or right lumbar region. Most of the tuberculous lump, they are more in a right lumbar region rather than in a right iliac fossa. That's what the pulling of cicatrization is that. So remain little bit malleable. You are hell-bent, it is tuberculosis and nothing else. What is the best thing? Whatever it is, when you describe that, you always put a possibility. Yes, sir. Yes, madam. I feel it is tuberculosis, but malignancy cannot be ruled out. Your trouble would be very less. Please continue.
Now, provisional diagnosis, cecal growth, and the differential diagnosis could be an appendicular mass, as mentioned, ileocecal tuberculosis, carcinoma tumor, right ovarian cyst or tumor, and Crohn's disease.
I think I'd like to point out, Beta, also said that I think first should be growth, justified. But the second, you should put ileocecal tuberculosis ahead of an appendicular lump, right? Because that history is too long for it to be an appendicular lump, right? So tuberculosis should be the second possibility rather than appendicular mass. Okay, please proceed.
Okay, why not an unascended kidney? Why not?
It could be an unascended kidney, but sir, the presentation, the age she was diagnosed, her age.
I mean, you've got a whole list. Why carcinoid? Why do you think it's carcinoid tumor?
Carcinoid tumor can isolated carcinoid tumor of the appendix can present as a may present as a lump in the right iliac.
You're right. Look, Vimal. I would have expected a cecal tumor carcinoma to be much higher up than a carcinoid. You have not mentioned that you've got carcinoid, you've got Crohn's. Right. So you look, Vimal. You're in third year. Right. You can't just give me any differential diagnosis. That's why I said, why not ascended kidney, unascended kidney? I can put anything there, right? So your diagnosis differential should be the one topmost, which is most likely, which you think. Okay, you might be thinking it's appendicular mass, fine. Then you have to prove it to me. Why you think it's an appendicular mass? What are the points in favor in history and examination? And why do you think next is ileocecal tuberculosis, which is less important than appendicular mass? And why carcinoid? Carcinoid is a very rare condition. I would have expected a CS cecum to be much higher up, right? Right. So, and why are you saying an ovarian cyst or a tumor? Right. You can feel the lower border.
Yes, sir. We can feel the lower border. So it's
unlikely. Can the mass be pushed into the pelvis?
Sir, in the case of right ovarian cyst or tumor, generally the lower border cannot be felt.
So you're feeling it, my dear. You're feeling it. So why mention it? You ruled it out. Look, you ruled it. So you're contradicting your own findings by giving your diagnosis, right? Okay. So let's redo your differential now.
So on redoing my differential, I would say that the first, which based on the clinical history, I would first differential diagnosis of mine would be ileocecal tuberculosis, sir.
Okay, why? Why not? Just give me a few points in favor in history and examination.
So based on the history, she was having just one positive history was there, sir, that she was having pulmonary tuberculosis 13 years back, and there is positive history of exposure with her husband.
Okay, just to please ma'am, you can't put ileocecal tuberculosis. Okay. Okay, so you just have a history of past history of tuberculosis. Anything else? Any fever? 2 months,
sir,
2 months history. Ileocecal tuberculosis, 2 months. And 60-year-old lady suddenly developing ileocecal tuberculosis at age of 60? Unlikely.
Unlikely.
There are no
Appendix.
constitutional symptoms of tuberculosis.
Right.
So it's probably more likely to be carcinoma cecum rather than an ileocecal tuberculosis.
Right. So next, appendicular mass. Now, why do you say that?
So, appendicular mass, if it would have been a case of 2 months history is too long for sir, and in this age group, it can be a malignant appendicular mass. It is a possibility, sir. Malignancy of the appendix, but apart from that, sir, there is no acute history of any attack in the recent past, sir.
So your ileocecal, your appendicular masses also goes out of the window. So the third diagnosis, let's complete a third differential. CS cecum.
CS cecum.
Right. Now go on. Why yes, why no?
Sir, first of all, the mass is felt high up as examined, sir.
And that's your finding. It could be what may be high to you may be low to me. So that's not the point.
And
what are the characteristics of cecal malignancies?
So the lump which will be felt, it will be irregular margin, and it will be hard to feel, sir.
Okay. What else in history?
In history, sir, the patient may present with episodes of alteration of bowel habits, or maybe there in history, sir, given by the patient. There may be loss of weight.
What are the 3 A's here? 3 A's here. Alteration of bowel is not a very common thing in CS cecum. It is anemia.
Anemia can be there, sir. Weight loss.
Asthenia.
Asthenia, weight loss. Yes.
Right.
Yes, sir.
And anorexia.
Anorexia.
Right. So these are general because they are vague. Why are they like, how is this right-sided different from left-sided malignancy?
So in right-sided malignancies, they present with generally they present with bleeding per rectum, sir. And in left-sided malignancies, they present with constipation, sir.
Bleeding per rectum is not big. Look, a 60-year-old lady presented to me with a cecal mass or a right iliac fossa mass for 2 months. I will go first for malignancy unless proved otherwise. Even if your symptoms are not there, classical symptoms are not there, right? So now, how will you proceed?
I would like to proceed with a few investigations.
Look, your original diagnosis is cecal growth, isn't it?
Yes, sir.
So you should have come up with it first. I mean, we have been going around. I didn't see that. Sorry.
It was cecal growth.
Yeah. Okay. So how will you proceed now?
So on my proceeding, few investigations were done for this patient, which were routine blood investigations, ECG, and to confirm whether.
Why will you do an ECG and a routine blood investigation at present? I want to confirm the diagnosis. I don't want to take the patient for surgery just now. Why do you want an ECG?
So imaging should be done for this patient, sir.
Right.
Yes, sir. On imaging, first imaging which I would like to do is a digital chest X-ray. I would like to get for ruling out any pox lesion which may be present and which may coincide with the findings. And since it was suggestive of infective etiology and it was obscuring the left postophrenic angle, her digital X-ray was suggestive of.
No. Your ultrasound. What does the ultrasound show?
On ultrasound, circumferential irregular wall thickening, 2 centimeter approximately, was noted in cecum with loss of normal gut signature. There were multiple hypoechoic rounded lymph nodes noted in the pericecal area. It was suggestive of malignant pathology.
Okay, so now with the diagnosis of malignancy, how will you proceed?
So with the diagnosis of malignancy, first thing which I would, since USG has been done to rule out, to find out the exact location and to rule out any distant metastasis. Or
no, you've got your ultrasound. Sorry, Bimal, you've already got your ultrasound.
Yes, sir.
What else would you like to look up in ultrasound?
So in the ultrasound, I would like to
In a case of malignancy or in ultrasound, what do you want to look for?
any abdominal metastasis nearby or skip.
You want to look at the liver, you want to look at the spleen, you want to look at lymph nodes, you want to look at fluid.
Yes.
Right?
The lymph nodes will be
right. So all those you'll have to look for.
Yes.
Then next, what would you like to do?
So I would like to go for a CCT of the whole abdomen with screening for the large bowel, sir, and terminal ileum.
Would you, I don't know, would you like to go for a CT or would you like to go for a colonoscopy?
Colonoscopy, I would, since we cannot rule out malignancy, considering her age, both colonoscopy and CT of the abdomen is necessary for further proceedings.
Okay. It's a preference. Some people get a CT done, some people get. Okay. Would you like to test for occult blood in stool?
Yes, sir. Occult blood in stool is a very much important test.
How do you test that? How do you test that now?
Sir?
How do you test for occult blood in stool?
Occult blood in stool, microscopically examination of for presence of RBCs.
No, you never do. People do Guai test, but nowadays there's a test called FIT. Fecal chemoluminescence test. It's called a FIT test, right? So that is done. Anything else?
Sir, for confirmation, I would also do a USG guided biopsy or FNAC of the swelling, sir.
You can do a biopsy while doing a colonoscopy.
Yes, sir.
Right. You don't USG guided. What's this? 2 centimeter. Come on, you'll not be able to hit it. Will you be able to catch it on the ultrasound? You will not. Right. So we'll go in for a colonoscopy. Okay. What else? What about CA? Is written CA?
Yes, sir. CA levels are to be checked for any kind, but since it is unspecific, we cannot say. CA is a marker which can be elevated in all kinds of abdominal carcinomas, including even in a case of pancreatic carcinoma or large colon, small colon, or in all
but
cases.
This patient doesn't have pancreatic carcinoma, no?
Yes, sir.
So in this patient, what's the importance of CA?
CA levels were examined, but it came out to be within normal limits, sir. They were normal, sir.
No, they were normal. I'm just asking. Suppose it was high. What's the importance of CA in a patient with colonic malignancies?
So it is a prognostic marker which is used for finding out post-operatively. In a case of rising trend of CA can be seen in recurrent cases. Screening
it's
for
not
CA
prognostic. It is for follow-up. If you remove the tumor, the CA should fall down.
Yes, sir.
If it recurs, the CA starts rising up. Okay. So please carry on, sir.
Thank you, sir.
Is the presence of CA a good sign or a bad sign? Yes, it can be a tool. It can be a good tool in the sense that if it is raised, then it should fall down. But would you like a patient, suppose he or she, God forbid, is your own relative, would you like to have him or her to be having a positive CA?
Positive CA and high levels of CA is a poor prognostic indicator, ma'am. Hello.
I'm sorry, the connectivity is not right.
Ma'am, I would like to repeat myself. As asked by you, ma'am, I would say that positive and high levels of carcinoma embryonic antigen, it is a poor prognostic indicator for any kind of colonic carcinoma, ma'am.
Very true, very true.
Yes, ma'am. Ma'am, am I audible, ma'am?
Vimal, I think madam's internet is little weak. That's why she has challenge. Let the other faculty ask questions, please.
Yes, sir.
Okay, sir.
Tell me that what are the various ways that tuberculosis can produce the lump in the abdomen? Jay? What are the various ways that tuberculosis can produce lump in the abdomen? Jay?
Sorry, sir, I couldn't get the question, sir.
No, I'm asking.
What are the ways abdominal tuberculosis can present in any abdominal tuberculosis? What are the types of presentation you have in abdominal tuberculosis?
Sir, generally, there are mainly there are two presentations which can be in a case of abdominal tuberculosis. Either it is an ulcerative variety or it can be a hyperplastic variety of abdominal tuberculosis.
Well, I'm not asking about the intestinal tuberculosis. I'm asking about the abdominal tuberculosis.
Abdominal tuberculosis, sir, it can present with enlarged lymph nodes. It can present with
produce a lump in the parietal wall of the abdomen.
I'm not sure, sir.
Have you heard about the cold abscess?
Yes, sir. Cold abscess, it can present, sir. It can present. Intra-abdominal.
Can it in the retroperitoneum producing a lump?
Pardon, sir?
Can the tuberculosis produce a lump in the retroperitoneum?
Yes, sir. In cases of renal tuberculosis, it can present as a lump in the retroperitoneum, sir.
Okay. Any other thing in the retroperitoneum?
Not sure, sir.
There is flexion deformity of the hip joint is there. Can you get that hint? The patient has a flexion deformity of the hip joint. You examine the back of the patient, there is a gibbus is there. Now tell how it can produce a lump in the abdomen.
I think we had initially also, I think somebody had pointed out that it could be a psoas abscess, and that is what we had made very clear also, that possibility of psoas should be ruled out. In the beginning also, we had said that you should look for a flexion deformity and you should look for any spinal abnormality in such cases. And that was very clearly mentioned. So please don't get worked up. Just have an open mind, and then I think you'll be able to do well.
Now come to the abdomen now. The various ways the abdominal, intra-abdominal tuberculosis can produce the lump. The lump which you are getting, how it is formed?
Sir, the lump, it can be, sir, the coiling of the coming up of the terminal ileum and coiling up of the intestine, the distal part of the small intestine, along with omentum coming up, so it can form a lump, sir.
I'm not asking about the appendicular lump there. I'm asking about the ileocecal tuberculosis. What type of the tuberculosis it is? Which is
sir, hyperplastic tuberculosis can form a lump, sir.
Right. So intestinal tuberculosis can be hyperplastic or it can be ulcerative. Now tell which is a primary tuberculosis and which is a secondary tuberculosis.
So in primary tuberculosis, sir, there is a concomitant. So the patient will be having pulmonary tuberculosis, and due to swallowing of the sputum by the patient, and there may be formation of there may be lodging of the tubercular bacilli within the small intestine, and sir, it can cause ulcerative lesions within the small intestine, sir. So that.
To ask you a simple question, hyperplastic type of tuberculosis is a primary tuberculosis or it's a secondary tuberculosis?
It is a secondary tuberculosis, sir.
No, it is a primary tuberculosis. Secondary tuberculosis is the ulcerative type of the tuberculosis, where the host resistance is poor, virulence of the bacteria is high, patient is continuously ingesting the bacilli through the lung tuberculosis. So that is a secondary variety. While here it is the Peyer's patches which are getting involved primarily by the Mycobacterium tuberculosis. So this is a primary tuberculosis, hyperplastic type of tuberculosis, the primary tuberculosis, while The ulcerative variety is the secondary tuberculosis. The patient has the good immune response and there's a low virulence of the bacteria, which leads to the hyperplastic type tuberculosis. Now tell other ways that abdominal tuberculosis produces the lump, apart from the intestinal tuberculosis. You know what is scabies mesenterica?
I've heard it, so sorry, but I'm sure.
What is that? Okay, big mesenteric lymphadenitis because of tuberculosis. That is called as scabies mesenterica. Do you know the cocoon formation?
Yes, sir. Abdominal cocoon formation due to tuberculosis can be there, sir.
What type of the tuberculosis it will be? Cocoon formation?
Sir, in a sir, where the host resistance is good, sir.
No,
and
which organ? Of which organ you find the cocoon formation?
from the visceral peritoneum.
Yeah, from the peritoneum.
Yes, sir.
So if the peritoneal tuberculosis is there, adhesive variety of the peritoneal tuberculosis is there, that will lead to a cocoon formation. So that can give the lump. Can you have a localized ascites in a patient with the tuberculosis?
Pardon, sir?
Localized ascites.
Localized ascites. Due to effusion, it can be there, sir.
That can also give rise to a lump in the abdomen. Okay, so there are various ways by which the tuberculosis can produce lump in the abdomen. Now, in this patient, you have done the ultrasound that is suggestive of malignant pathology. What will be your next investigation now?
Now, apart from this, we can go for, sir, as mentioned, sir, CD abdominal colonoscopy should be done in this case, sir.
Okay, why you want to do a colonoscopy? What is the
sir, to find out whether this is an exophytic variant or there is any intraluminal part of whether there is any intraluminal part associated with this exophytic variant, whether it is an obscuring the lumen, and if it is obscuring the lumen, so we should also, if via endoscopy, we should take a biopsy from the specimen and confirm our diagnosis, sir.
Vimal, it seems we are stuck on ultrasonography. Will you move forward? Have you done any other investigations?
Yes, sir. Done, sir.
Why you are stuck in ultrasonography? You move forward if you have done anything else.
In contrast, computed tomography, there was a heterogeneously enhancing exophytic mass in the right iliac fossa, possibly arising from the wall of the terminal ileum with surrounding lymph nodes, suggestive of neoplastic pathology. Query was given as GIST, and FNAC from the swelling was suggestive of GIST. On colonoscopy, it was unremarkable, and impression was normal study, sir. Scope was passed up to the cecum. The normal fecal matter was present and no growth was seen, sir.
What are the things you are going to do on colonoscopy?
Pardon, sir?
Apart from looking at the primary pathology which is there, what are your other interests when you are doing a colonoscopy? What other things you want to look?
So, other things what I would like to look is for the presence of any transverse ulcers within the lumen of the bowel, so that we can rule out tuberculosis, sir.
You would like to see for any synchronous malignancy.
Synchronous and
yeah, you know what is synchronous malignancy? What do you understand by that?
Synchronous malignancy is malignancy which is near to the primary malignancy. Any other malignant lesion which is seen, that is called synchronous malignancy.
Like if you have done a...
Can there be some lesions within the colon which are associated with... Okay. Yes. Can there be some lesions which might be associated with a malignancy in the colon? Besides, of course, synchronous lesions of carcinoma colon, there may be multiple which is a high risk factor for carcinoma colon. Would you not like to see that as well?
Pardon, ma'am, I didn't get the question. I would like to answer.
What are the risk factors for carcinoma colon? Would you not like to see whether the
Yes,
colon
ma'am.
is having some sort of a might be a risk factor for
Presence of
carcinoma colon?
Presence of multiple polyps can be a risk factor for carcinoma colon, sir, ma'am. And multiple polyps, more than 100.
The colonoscopy is done for three purposes. One is to look at the primary pathology and take a biopsy of that. Second is to look for any synchronous pathology which is there. And third is to look for any pre-existing cause for that. Okay, so these are three reasons that why you want to do a colonoscopy. Okay. Then after this, what you have done?
Even inflammatory risk factor.
Have you done any other investigations after colonoscopy?
After colonoscopy, sir, there was a we approached for this case we approached surgically we approached the patient, and first of all we like to confirm the diagnosis by doing a laparoscopic examination of the abdomen, sir, and then proceed, sir.
What did you find on laparoscopy?
On laparoscopic examination, sir, an exophytic lesion was found near the distal ileum, and it was obscuring the medial margin of the colon, sir, medial margin of the cecum, sir.
What did you do?
We approached laparoscopically, and laparoscopy assisted localized excision of the gist tumor was done under general anesthesia. A large gist in terminal ileum and involving the medial border of cecum was seen. However, appendix was normal. Terminal ileum about 8 centimeter and cecum with appendix was excised, and end-to-end ileocolic anastomosis was done. Histopathological examination report for the excised specimen is awaited, sir.
What various histopathological examination you want to do for the patient suspected of the gist? Yes. What are the various pathological diagnoses you want to carry out for the gist?
Sir, for gist, the tumor markers for gist have to be done, and immunohistochemistry staining of the excised specimen has to be done, sir. First of all, I would like to go through a microscopic examination of the tissue bits which were after processing, and I may see spindle cells along with atypical nuclei or ovoid-shaped nuclei may be found. And on immunohistochemistry staining, sir, markers of gist may be seen, sir, which are CD 117 and sometimes CD 34 may be there, sir.
Waiting for the report?
Pardon, sir?
Are you still waiting for the report of that?
Yes, sir, it's still awaited, sir, here.
Okay. Now tell, what are the prognostic factors in the gist?
So prognostic factors, I would say that first of all, the size of the gist is an important prognostic factor. A size of more than 2 centimeter for the gist warrants immediate excision of the gist, and definitely, sir, the patient has to be followed up.
What thing should not be done when you are operating this patient? What's the one of the most important thing which is there, which you should not do? At the time of the operation.
I didn't get you, sir.
What are the things which you are not supposed to do while operating for a GIST resection?
The most important is that you should never rupture the tumor, because that is one of the very important prognostic sign which is there. So you should never rupture the tumor when you are operating. You should take all care that your tumor doesn't get ruptured. Okay. So you get the biopsy report as it's a case of a GIST. What further you are going to do?
Sir, based on the size, first of all, I would say that, as mentioned, sir, more than 2 centimeters, we have to follow the patient on regular intervals. And, sir, we have to start the patient on tyrosine kinase inhibitors, sir.
Which one you will start?
Sir, pardon, sir?
Which drug do you start?
How much
sir,
dose for that and how long you are going to give it?
So we have to start the patient on imatinib methicillate, sir, tablet.
How much dose you are going to give?
So we have to give the patient 400 milligram once daily doses, sir.
How long you are going to give it?
Sir, for a period of 3 to 5 years, sir, with
Okay. The minimum is 3 years, है ना?
yes, sir.
Now, what are the things you are going to monitor while you are giving the patient the imatinib?
Recurrence has to be seen, sir, because this is one tumor where recurrence is very common, sir. So we have to monitor that whether the patient is going into recurrence, sir.
Monitor the drug.
Sir?
How will you monitor the drug? Can it cause any side effects?
LFT may be deranged, sir. And
Opinion.
yes, sir. And there may be compression of bone marrow compression may be there, sir.
Okay.
Madam, okay, sir, madam, you would like to add any points, madam?
No, nothing whatsoever. I think we have had a wonderful discussion. And I think let us wind up now.
Sure.
My
Rajesh?
net is not working very well, sir. As
I
you must have
understand, madam. I understand the difficulty what you're facing. Rajesh, sir?
You're fine, sir. I think it's
Karnakaran, sir?
gone through.
Ganguly, sir, you would like to
Yes.
give any internal faculty comments?
Yes, definitely. I'd like to speak a few minutes. Please give me two minutes time.
Please, sir.
Dr. Kanagavilu, thank you very much giving my PG that beautiful chance to present his case in presence of such august gathering. First is that I'm thankful to you. Second, I'm very much thankful to Professor Sahai, Professor, I think Atish, Lady Professor, yes, and Dr. Khanna, looking at you, we sometimes get scared. So we are very, very happy, thankful, and grateful for your guidance. But sir, one request, whatever the mistake he has done, all mistakes I take this responsibility for. But sir, I just want to put forward one of my suggestions, sir, that we are different in little bit different ways. So because we have some regional differences, we had different kind of teachers. So maybe there are some institutional philosophies are there during presentation of cases or something like that. And Professor Khanna, I told you once, sir, that I cannot change my style now. We are more into elaborations. So I'm telling you, sir, my students will always present with more information than probably you will like to listen. But please bear with them, because this is the way we try to make them understand that if you miss a point, sometimes you actually cause a catastrophe. So that's why our idea is to let them teach or let them learn how much information you can gather. But what Professor Sahai has guided him, that the way he presented afterwards was defective, and I'm so very thankful to you that you have guided him properly. And I'm happy that being a second year postgraduate students, and then also after Corona time and doing so much of duty, Dr. Vimal Majumdar has presented so well. And really my assistant professor, Dr. Manavjyoti Gohai, he has guided him very well. there are shortcomings in our side, sir. We are a new college. Of course, I am a senior faculty, but rest of all are very junior. And actually, last 7 days I was taking exam in another college, so actually I could not brush him up. So all the things what he has done wrong, sir, I'm taking responsibility, and my heartfelt thanks to all of you, sir. And thanks very much, sir. Thank you and good night, sir. Thanks.
Never thought I am so scary.
Yes, sir.
So friendly.
I always tell them that you have to listen to Professor Khanna and learn from him, and Dr. Sahai, of course.
Sir, it is not that a responsibility, sir. The idea of these classes are only for the students to learn from diverse faculty across the country. See, now this becomes an opportunity for the student to know what the other examiners also expect, that is all.
Yes.
So let departments have their own standard of teaching and their own standard of presentation. Every state has little subtle changes, but this is quite a different forum, so that this is a teaching forum. It is not for someone to criticize or anything. You need not feel bad for or feel sorry for this. It is a teaching thing. All of us have
sir,
gone through as students.
I'm not sorry, sir. I'm feeling very happy that he has guided properly. But what I'm telling you that you will have to tolerate my audacity. When my students will be there will be lots of informations, more than what you want to hear, sir. That is my philosophy. I'll keep on teaching that.
All of us have shortcomings in the first year, second year students. Then let's how things are happening now, sir. Anyway, very happy that students are coming forward in spite of their in the second year and the challenging situation. So, any other comments, sir? Khanna sir or seniors here?
Okay. I would just like to say,
yes, sir.
Professor Ganguly, actually things are evolving very fast now. Time is less for the student to present his case in an examination. That's why we want to them to present a compact history and examination, so that they get more chance to answer questions, so that they can collect marks. So this is with this concept, the whole history taking has taken has undergone a change. Even here, even in MRCS, everywhere in this thing has gone under change.
Yes.
So that is why we're trying to evolve around.
Yes. Thank you, sir.
Thank you, everyone. Thank you, dear students.
Last 1 year, Dr. Ganguly, Dr. Kanagal has been doing such a hard work to teach our students all over India.
Yes, sir.
And along with so many faculty, very senior faculty which are there, Dr. Rajiv Sai is there, Dr. Shenoy is there, Dr. Chandrasekhar is there, just forgetting, so many persons. So, and they are very senior persons, and, many things you will not get in the books. Whatever the way the students they read, whatever senior teachers will give them, they will not get in the books. And these are the type of the questions which will be asked by one or the other examiner.
Yes.
So here we are only for teaching purpose. It is not that we are going to, pull the legs of the students or like that. It is not, absolutely not.
I know, sir.
Yeah, it is only for teaching the students, so that whenever they get such type of the things which is in there, they can go away with that. That is the only thing. And I think Dr. Kanagal must be congratulated for that.
Yes,
the last 1 year, almost 1 year it is now there, that he's carrying out this. Yesterday, Rajasthan, they started that PG clinic. And I was the first one in that. So I told them about Dr. Kanagal that you go and meet Dr. Kanagal, that how he's carrying out these activities for last 1 year.
True, sir. True, sir.
Yep. Thank you.
Thank you, sir.
Thank you very much.
I think next class will be our anniversary class of first year. So I am planning for more initiatives, sir. I will take inputs from you tomorrow in person, sir. Thank you, one and all. And with that, I thank the students who are watching in the YouTube for joining us this evening. We will look forward to have more interesting cases in the coming week, and we are also trying to expand ourselves to other platforms like Facebook and Instagram. Many students have requested that they want in other platforms, because some students do not have access to Facebook. I don't know what does that mean, but we are expanding to other channels also. That is the request from the students. I'm working on it. So hopefully we will be able to touch more students through this way. So with that information, I will